video, the focus will be on pharmacologic agents for the treatment of multiple sclerosis, or MS, which is generally thought to be now an immune-mediated inflammatory disease, but before it was actually thought to be considered an autoimmune disease due to some unknown autoantigen. But now we generally consider this an immune-mediated inflammatory disease. So the good news is the schematic should look pretty familiar and similar to those from the videos in Block 5 and other blocks, which means we'll keep the immunology overview brief since we are now in Block 6. And this also means many of the agents we will discuss for the treatment of MS will be the same or similar to many of the agents we have already discussed in past videos. So MS is a disease where inappropriate immune cell reactivity and inflammation in the CNS leads to demyelination and neuronal loss over time. So the way in which we get to these outcomes isn't entirely clear, but it is thought to begin with an autoreactive T cell. But again, it's not clear if there is some sort of autoantigen involved. But again, it's not clear if there's some sort of autoantigen involved or if there is some sort of imbalance in the T cell regulation. But once we have this autoreactive T cell in our lymph node, for instance, the active autoreactive T cell must migrate from the lymph node into the vasculature. And one important regulator in this migration is sphingosine 1-phosphate, or S1P, which is a bioactive lipid modulator that binds its respective receptor on immune cells to trigger this aggression of the T cell into the blood. Now, the next barrier will be the blood-brain barrier, and in MS, with its heightened inflammatory state, there is blood-brain barrier dysfunction and leakiness, which will be a key point moving forward. So our autoreactive T cells with our alpha-4 integrins can interact with our VCAM1 on our endothelial cells to promote that transmigration across that dysfunctional blood-brain barrier to finally reach that CNS. So once in the CNS, there is a release of those pro-inflammatory signals to begin that immune-mediated cascade at the macrophages down to the pro-inflammatory TH cell population, then to those B cells that become those plasma cells that go on to secrete those demyelinating antibodies. This cascade is also going to further go on to activate other macrophages as well as cytotoxic T cells, all of which are going to mount an immune-mediated response against our myelin sheaths and our oligodendrocytes. This will lead to that demyelination and loss of oligodendrocytes, which are needed to insulate our axons and propagate neuronal signals efficiently. So without this, there is a loss of signal transduction and a wide range of MS signs and symptoms. Now, another key component here is that this high level of inflammation usually comes with a lack of immunoregulatory T cells. So those checks and balances within the immune cell populations are lost or limited. So moving to our next slide. So now that we understand what is known regarding the pathophys of MS, you can probably begin guessing how MS treatments may correct this inappropriate immune-mediated response against the myelin and oligodendrocytes. Again, some of the agents we discuss may be new to you, but many other mechanisms of action will be similar to those from previous blocks. And as always, we're going to start with our agents working outside of the cell, and we'll start with the monoclonal antibodies. But I do want to point out that even though we have this dysfunctional blood-brain barrier, and I will show the drugs on this slide mostly inside the blood-brain barrier, the monoclonal antibodies still cannot reach target levels in the CNS and cross it effectively. So most of these effects will be on the immune cell populations before they can actually reach the CNS, okay? So now I won't go over the adverse drug reactions for antibodies again, since we did that back in Block 5 quite a bit. But just remember, we have those hypersensitivity reactions, we have that risk of infection, malignancy, and activation of latent infections. And then I'll point out some unique ADRs as we go. First agents we're going to discuss are going to be ofatumumab, which is a human monoclonal antibody against a tumor. And we're also going to discuss ocrelizumab, which you may see commercials for this one being Ocrevus. which is a humanized monoclonal antibody against an immune ligand. And even though their naming is not consistent, these agents work similarly as rituximab, which we've discussed a lot before. So these agents will address this B cell arm of this immune cascade by binding CD20, which, remember, is an antigen found on pre-immature B cells, and when bound by either ofatumumab or ocrelizumab, this will induce apoptosis of these targeted cells so that they cannot become those plasma cells and secrete those demyelinating antibodies that are a significant driver in this neuronal demyelination. As for new adverse drug reactions, we haven't talked about yet. So for these agents, because we are depleting an immune cell population, there's going to be a risk of PML, or progressive multifocal leukoencephalopathy, which is a rare and often fatal viral disease that's characterized by this progressive damage and inflammation of the brain. So it's caused by the JC virus, which is normally harmless and generally present, but it's kept under control by the immune system. But once our immune cell populations start being depleted, the risk of PML increases because this virus in the CNS cannot be kept in check. So this will be a new common adverse drug reaction to add to the list we've already created for our monoclonal antibodies that deplete the immune cell populations. The next biologic that we are going to discuss is alemtuzumab, which is again monoclonal antibody, humanized, tumor. And it is tumor because it can be used for CLL, but this agent is also going to target an immune cell surface marker, but instead of targeting CD20, we are targeting CD52, which is found not only on our B cells, but our T cells, as well as our macrophages. So we're depleting multiple immune cell populations through a similar mechanism of action as our last monoclonal antibodies. So they can no longer participate in this demyelination. So as for adverse drug reactions, again, we have PML, along with the risk of MI and stroke, which usually happens within the first few days of therapy. And there's also going to be a risk of autoimmune mediated disorders due to a depletion of those Treg cells, because these cells are also going to have CD52. So because of this longer list of more severe risks, this agent is reserved for those that have inadequate response to other agents, and there is a REMS program to monitor use of this agent. Our next agent is going to be natalizumab, which again, monoclonal antibody, humanized immune ligand. And this is going to be targeted at our alpha-4 subunit of the alpha-4 beta-1 and beta-7 integrins that are essential for that adhesion and transmigration of those autoreactive T cells into the CNS. So by binding these integrin subunits, we block those T cells from any participation in propagating that inappropriate immune-mediated response in the CNS at the myelin sheaths. So natalizumab should remind you of vedolizumab or Entyvio from the IBD video, which also has a similar mechanism of action by targeting integrins, but just more with a GI-specific mechanism. So our adverse drug reactions are going to include hepatotoxicity. There is also going to be a risk of PML again, because we are preventing those immune cells accessing the CNS, and there is also a REMS program for this agent because of this risk of PML. So now we're going to move on from our monoclonal antibodies to two other types of agents we're going to address on this slide. So the first class will be our sphingosine 1-phosphate receptor modulators, which we discussed one specific agent being ozanimod or Zeposia back in the IBD video. But this class, which includes a number of other agents that end in this IMOD ending, where the MOD should hint towards the modulator effect. But these agents can also be used in MS, not only IBD. So these sphingosine 1-phosphate receptor modulators are small molecules that will bind to our S1P receptors, which are important again for those autoreactive T cells to move from the lymph node to the circulation and then to reach that CNS. So when ozanimod, for example, binds the S1P receptor, it will prevent it from binding S1P and will actually lead to receptor internalization. So this will trap that autoreactive T cell within the lymph node, reducing the number of T cells available to even enter the CNS to elicit their effects. So as for important pharmacologic considerations, these agents can lead to bradycardia and require cardiac evaluation prior to use and cannot be used in patients with a recent MI, stroke, decompensated heart failure, QT prolongation, and some anti-arrhythmic drugs as well. So liver enzyme elevations can also occur and will need to be monitored for. And then we're also going to have that risk of PML again. Now, our last agent we're going to discuss on this slide is glatiramer acetate, which is a more conventional MS agent given sub-Q and is an immunomodulator, and it's thought to work in MS because it mimics the myelin basic protein and may divert the immune response from the actual myelin. And for instance, we can swap it in here in our antigen presenting cells, which may then interfere with downstream T cell activation, while also promoting those immunoregulatory T cells that dampen the immune response to restore some balance, because remember that T regulatory activity is thought to be limited in MS. So altogether, you can see why these effects will be efficacious in MS. And as for side effects, these are generally less so than the other agents we already discussed on the slide, but there can be a risk of chest pain, as well as injection site reactions. There could be hepatic injury, and allergic reactions as well. So moving to our next slide. So this concludes our discussion of agents working at this level of our schematic. Now let's zoom in on one of our immune cells and discuss the agents that will be working in MS at various intracellular targets. So moving to our next slide. So for our agents working inside our autoreactive T cells, for instance, all of these agents we have either talked about already in previous blocks or talked about a related agent that will share a similar mechanism of action that was used in a different context besides MS. So our first agents that we will just mention are our corticosteroids, which you all should be pros when it comes to their mechanism of action and adverse drug reaction profile. So take a minute either now or at the end of this video to review their pharmacology if needed. And the same rules apply as before, where these will be used initially and short term for acute exacerbations or episodes because of the long list of adverse drug reactions that come with more chronic steroid therapy. Now we will transition to one of the immunotherapy options for MS that was discussed back in block 2 for CML. And this is our recombinant forms of interferons, like our interferon beta. So interferons are cytokines, and most think of them as being released by host cells in response to viral infections. But actually, these cytokines coordinate a number of immunomodulatory responses. However, the underlying mechanism of action is somewhat unknown. But in the case of interferons administered as a therapy for MS, it's thought to act on our autoreactive immune cells to inhibit proliferation and survival signals and promote those apoptotic signals. So interferons are also thought to act upon our regulatory immune cells to enhance their response against the inappropriate immune-mediated attack of myelin sheaths. So this immunotherapy acts both directly and indirectly to correct those immune imbalances promoting MS. So with this exogenous stimulation of the immune system, there are some downsides. So this therapy is going to cause flu-like symptoms and places the patient at risk for autoimmune related inflammation in a number of tissues, which makes sense with its mechanism of action and activity at these immune regulators. So there are some other severe adverse reactions too, and there is also a risk that the body will generate neutralizing antibodies against this recombinant interferon, and this will limit its therapeutic effect. So monitoring for these antibodies and response to therapy will be key. So for MS, this is an option, but a number of precautions to be aware of and adverse drug reactions to monitor for. So our next agent for this slide is cladribine, which is very similar mechanism of action and adverse drug reaction profile as cytarabine, which was also discussed in the CML case back in block 2. So cladribine is an anti-metabolite, again meaning that it acts as a false substrate or metabolite in a biochemical reaction involved in DNA synthesis. So this agent is a nucleoside analog that mimics adenosine, and it enters our immune cells through nucleoside transporters on the cell membrane, and once inside the cell, the adenosine analog is triphosphorylated to 2-CD-ATP. And once in its active form, it can compete with normal pools of DATP to either inhibit DNA polymerase or be misincorporated into the newly synthesized DNA as a dummy nucleotide, and this lesion can induce apoptosis. So this agent's dosing scheme is unique in that it's given for a few days, then you wait a month, give it for another few days, wait until the following next year, repeat again, and then your cladribine treatment is complete, which is thought to interrupt the cascade of MS that's on our other schematic without having those extreme adverse drug reactions, usually associated with agents that have these traditional chemotherapy mechanism of action. However, if you do look up the adverse drug reactions for cladribine, you will still see some of those side effects listed from targeting those rapidly dividing cells in the body. So still monitoring for those, but hopefully the risk would be less. There's also going to be a risk of PML from depleting those T and B cell populations. So for our next agent, we actually discussed its prodrug in the RA video, which was leflunomide. But now we're just going to discuss its active form, which is teriflunomide, which can be used in MS, and we will now just do a very brief review of its mechanism of action. So teriflunomide works through inhibition of dihydroorotate dehydrogenase, which is an enzyme responsible for mitochondrial de novo pyrimidine synthesis. So by depleting our pyrimidine supply, there is this inhibition of immune cell proliferation and function. So just like leflunomide, teriflunomide will have the same adverse drug reaction and pharmacokinetic considerations that we discussed in the RA video in block 5. Now our next agent is mitoxantrone, which is very similar to our anthracyclines like doxorubicin from the non-Hodgkin's lymphoma video back in block 5. So mitoxantrone works just like the anthracyclines by intercalating into DNA, which blocks replication, but also interacts with topoisomerase 2, inhibiting its normal function and causing those DNA breaks that eventually trigger apoptosis in our rapidly dividing cellular populations like our autoreactive immune cells. So mitoxantrone was actually developed to hopefully minimize the risk of cardiotoxicity seen with doxorubicin, but unfortunately that didn't really work out, and the biggest adverse drug reaction for this agent is still going to be cardiotoxicity. And it's going to have a very similar adverse drug reaction profile to those anthracyclines we talked about in block 5. Our last agents for this slide will be the fumarates, like dimethylfumarate, and the exact mechanism of action of these agents is not really known, but it's thought to degrade to its active monomethylfumarate, which can then, through likely the transcription factor NRF2, alter gene expression to promote apoptotic genes and suppress cytokine production and other pro-inflammatory genes in immune cells. But it's also thought to promote neuroprotective genes in our oligodendrocytes, like those genes that are involved in dealing with oxidative stress, for example. As for adverse drug reactions, these agents are generally more well tolerated compared to the other agents on the slide, mostly flushing and GI side effects, but can lead to lymphocytopenia, which would then increase that risk of PML. So monitoring for a CBC is going to be needed. So moving to our next slide. So this concludes our discussion of agents targeting these intracellular targets to elicit either immunosuppressive and or immunomodulatory effects, most of which should have been a nice review of pharmacology from previous videos, but now just in the context of MS. So moving on to our final slide. So in summary, even though the pathophysiology behind MS is not entirely clear, we can leverage what we do know and target those autoreactive immune cell populations known to play a role in this progressive demyelination of MS. And because there are a number of mechanistic similarities across MS and other immune-related or autoimmune diseases, many of the therapeutics indicated for MS we've already discussed in other disease contexts, or they just share a similar mechanism of action and adverse drug reaction profile. So keep in mind that some of the agents we discussed today come with a much more risky adverse drug reaction profile than others, so setting expectations with patients, balancing efficacy and toxicity, and the need for monitoring will be necessary.